fill out this survey for the CE office, but typically it's more going forward for newer, or if you're interested in other projects, you can indicate that there for us and we can include you on those listservs. I'm Elizabeth Minnick, I'm with Project Echo, and I will start with Dr. Hott. I can't hear you. We can't hear you, Dr. Hott.
Muted, Dr. Hott.
No worries, no worries. I was trying to read your lips.
I'm Mark Out from the Rockefeller Neuroscience Institute, and I work in our memory clinic here and specialize in evaluating and treating patients with Alzheimer's disease and other dementias.
Thank you so much. All right, Teresa, please.
Making sure I'm not muted.
Sorry.
I am usually that person. So I'm Teresa Morris from the West Virginia chapter of the Alzheimer's Association, and I am the program director. So I take care of education, support groups, and any programs that we hold.
Great, thank you so much. Good to see you again. And Amy?
Hello, so I am Amy Boehm and I am the Health Systems Director with the Alzheimer's Association. So I work with Teresa and other health systems across our region. And just a quick note of gratitude. Thank you to Mitra and Jay. I know that you spent some time talking to Humana and Aetna as they're looking at starting their own Project Echo. So thank you for taking the time to speak to some other health systems that are interested in doing some of the work that you guys have already done.
Great, thank you so much. And Dr. Paliwal?
Hi, I'm Dr. Paliwal. Yeah, I'm family medicine. I'm working here at MVA Fairmont Clinic at Fairmont. Thank you.
Thank you. Dr. Ward?
So I'm Melanie Ward. I'm one of the neurologists here at WVU. So I do MS, and then also I'm working the cognitive clinic. So here I am. I was getting my slides up pulled on my computer. That's why I looked distracted there for a minute.
No worries. And I'll have those ready for you too. Not a problem. And Sierra Keith, please.
Hi, I'm Sierra Keith. I'm a neuropsychologist here at WVU. I work both in outpatient psychiatry as well as at the memory clinic over at RNI.
Thank you so much. Great to see you. And Osvaldo Navia, please.
Yes, hi. I'm Dr. Navia. I'm Chief of Geriatrics, Palliative Medicine, and Hospice. I work in multiple settings around Ruby Memorial, UTC, and different other clinics belong to the system. And also I work in the memory clinic. Thank you.
Thank you so much. Great to have you. And Donna Barton.
Hi, I'm Donna Burton. I'm a nurse practitioner at Systemville Health Center with Cabin Creek Health Systems.
Great, thank you. And last but not least, Mitra.
Hey everyone, I'm Mitra with Project Echo. Thanks, Elizabeth.
Of course. All right, Dr. Ward, I will go ahead and pull up your slides for you.
Okay.
All right, and then we can begin.
Okay, so today we're going to talk a little bit about referrals and specialty testing for cognitive problems. So we can go to the next slide. And there's just a little outline there. I'm going to talk a little bit about referrals and then all the different testing that we may get as part of a dementia workup. You can go ahead. And one more. Okay, so when to make a referral for a patient, because obviously a lot of patients will come in with cognitive issues, and sometimes it can be questionable, do they need a specialty referral or not? So what I would say first about that is, you know, anytime that it's felt like a referral to a specialist, a neurologist, or a dedicated cognitive neurologist, anytime it's felt that that's appropriate, it probably is appropriate, and we're very happy to see patients from all walks of cognitive trouble in our clinics. So if there's concern from a provider standpoint, if a patient or family would like to have a specialty opinion, I think it's never wrong to make a referral. But you especially want to think about it more frequently if there are any atypical features or red flags. And so some common things that would be, again, sort of red flags that would raise suspicion for either a more complex issue going on or something else, it's not neurodegenerative or kind of run-of-the-mill dementia. So younger age at onset, so age less than 65, would be a little bit atypical for a lot of these other more common cognitive diseases. So that's, that would be a reason to think about specialty referral. Patients who are declining really rapidly can raise concern for something else going on. People who have a lot of fluctuations in their symptoms, so like one day they're normal, the next day they're really bad, 1 hour they're normal, the next hour they're really bad, that could raise concern for something else going on. People who have high risk exposure, so known exposure to toxins, or people who are on a lot of medications, or people who have infectious risk factors, so like high risk sexual behaviors or IV drug use. And then if there are concerning findings on exam, so either focal findings on exam like unilateral weakness, numbness, increased reflexes that would raise concern for potentially an underlying structural lesion, or if there's concern for something like normal pressure hydrocephalus. So those patients often have very shuffling or magnetic gait and things like incontinence, along with their memory problems. It would be useful to get a specialty opinion on that, because that's one thing that has a treatment. And then other things like abnormal movements. So with things like Huntington's disease, you can get a lot of cognitive and psychiatric issues, and also chorea. And there's a lot of other diseases sort of in those families that, have cognitive issues as part of sort of a larger picture. So those are some red flags to think about when thinking about who needs a referral and who may not. Okay, you can go forward, I think probably 2 slides, yeah. So then we'll talk about specialty testing. So when we're thinking about why should we do all these testing, it's important to think about what we're hoping to achieve with our diagnostic evaluation. So the goals of the evaluation would be, 1, to make sure we're not missing something that's reversible or that has a drastically different treatment plan from some of these other diseases. The second would be to provide the patient and their family members with an accurate prognosis. So depending on which disease they have, sometimes there can be widely different prognoses in terms of life expectancy or other symptoms to be on the lookout for. So for example, if we are diagnosing with someone with something like Lewy body dementia versus Alzheimer's, there are going to be different things to be on the lookout for in terms of sleep problems and hallucinations and behavior problems and things like that. So it's useful to distinguish what subtype of dementia someone may have so that we can sort of set expectations. It's also often useful for people, again, to have an idea of like, here's what things may look like going forward in both the short and long term, so that they can make plans. And also it makes it a little bit distressing, a little bit less distressing when some of these things happen, if people are aware from the beginning that that's something that could possibly arise. And then also directing treatment plans. So a lot of these problems have similar treatments, but there are definitely exceptions to that rule. And so having the most accurate diagnosis helps us know the best way to treat the patient. Okay, so we can go to the next slide. So I sort of started from the simplest evaluations, and then we'll work our way up to the more complex ones. So as part of kind of a standard workup for cognitive changes, it's useful to check just sort of general labs, a CBC and a serum creatinine, to include things like a bad anemia or renal failure, which could definitely have cognitive consequences. And then we pretty much always check B12 and TSH, because again, those are kind of fixable problems to an extent. So if the B12 deficiency, actually fixing the underlying deficiency does not always resolve this neurologic sequelae of a deficiency. But again, it does definitely change your management, and these are relatively easy tests to get that can at least exclude a more treatable etiology. It is not recommended to routinely check RPR for syphilis or HIV on every patient. So you sort of select that depending on other risk factors they may have. So if there are risk factors, then definitely you should check those, but you don't necessarily, the guidelines do not suggest testing them in every single patient. And then other things, again, kind of depending on lifestyle or other risk factors, you may want to check some other nutritional labs. So thiamine deficiency is more higher on our suspicious list for patients who have a history of alcohol abuse or other GI issues or history of like a gastric bypass or other weight loss surgeries. So actually last week on our inpatient service here, we had 2 different patients who came in with thiamine deficiency after gastric bypass surgery. So again, depending on what other issues they may have, you might think about other nutritional labs. Okay, you can move forward. And so then as part of our specialty evaluation, we get neuropsychiatric testing on pretty much everyone we see. So there are screening tests that can be done in sort of a general clinic visit with anybody. So those are things that we're all familiar with, like the mini mental status exam or the Montreal cognitive assessment. There's another one called the St. Louis University mental status exam, which I don't do that frequently. I usually rely on MoCA if I'm seeing someone in my regular clinic and it's not sort of a dedicated comprehensive memory clinic visit. These are good kind of screening tests that can give you an idea of where, how bad is someone doing and where are their deficits more concentrated. These are not definitive testing, and definitely they don't specifically give you a diagnosis, but again, it's useful as a screening tool. And then specialty neuropsychological testing, which is what our colleagues, Dr. Houghton and Dr. Keith, and our other cognitive neuropsychologists in our clinic do, is a much more sophisticated measures of different cognitive domains. It's very useful to identify kind of subtle abnormalities that might not be obvious on MoCA or mini mental status exam. And it is not uncommon for us to see someone who has a score within the normal range on one of those screening tests, but when we do sort of more formal testing, we can pull out more subtle deficits that are very clinically meaningful. And it's also always useful for me to remember, especially when I'm seeing patients who, even after their more thorough evaluation, we think, well, you're actually doing relatively well from a cognitive standpoint. It's important to remember that, especially for people who start out kind of very highly functioning, if this is where they started and this is normal, if they go from here to here, they're going to notice a big difference in their day-to-day functioning, even though we might be tempted to say, well, hey, your mini mental status exam was normal, so have a nice life, your brain is fine. So it's really useful, again, to pull out some of those more subtle deficits, and then also for following over time, because we definitely sometimes can appreciate more change as time goes on. So even if we think someone is doing pretty well overall, it's useful to have sort of a thorough baseline evaluation so that in a year, if they are worse, we can go back and compare. And then the patterns of impairment that we may see on formal neuropsychological testing can help us figure out what's going on. Is this in a pattern like we typically see with a neurodegenerative disease? Does it look like mood is playing more of a role here than we anticipated, or medicines, or things like that? Okay, you can go to the next testing or slide. So then I will move to imaging studies. So there are lots of different imaging tests that we can get, and each one can be helpful in its own ways and also has some limitations. So a CT scan would be a common imaging study that a lot of patients have even before they come to see us. And CTs definitely have their useful points. So they're quick tests, so they're useful for people who can't tolerate MRI. So if you have somebody who can't lay flat long enough for an MRI, or who can't lay still long enough for an MRI, a CT scan is really quick. It's also less expensive than an MRI. So when we're thinking sometimes about healthcare utilization, CTs are often less expensive than some of the other tests we do, and they can give you very helpful information. So this top picture here is a good example of multiple findings we can see on a CT scan. So you can see some atrophy definitely on that CT, and then also these hypodensities. I'm guessing probably my mouse won't show up here, but these sort of darker areas you can see that with chronic ischemic changes. So if we saw this CT on a person who had a clinical picture that was consistent with either, you know, Alzheimer's or vascular dementia, we can get useful information from the CT that may support that. And then the bottom scan, so again, I should have thought about the fact that if I'm not in control, I won't have the pointer, but this is an example of a chronic subdural hematoma. So if you see over on the patient's right, the left side on the scan, you can see that kind of fluid collection overlying the brain. Yes, you got it there. So CTs are useful for seeing things like blood, and that can be very helpful too in figuring out, you know, how much of a person's problem may be acute or chronic. So they're not, you know, the most intricate, detailed examinations, but they definitely can be very useful. And the other setting that CTs are useful are in patients who can't get MRI because they have a device that's incompatible. So some patients have, you know, MRI incompatible pacemakers, or when one particular patient of mine has a bullet fragment that's been chronically lodged right underneath their heart, and I have not wanted to risk moving that with the MRI magnet. So CTs it is for them. Okay, so we can go to the next slide. So then the next modality, which is probably the most common imaging study that we utilize, would be an MRI scan. And MRIs are great because they can give you a lot of detailed information about the structure of someone's brain. So in this example, and I have a few examples of different things we may see on an MRI. The top row there is a normal, relatively normal MRI. As compared to the bottom row there, you can see a lot of atrophy. And then you can also see that that person's ventricles are a little larger than normal. That's in this case, and we'll show an example of NPH in a minute, their ventricles are enlarged kind of in proportion to their degree of atrophy. You can see a little more atrophy notable in the temporal lobes there and the hippocampi. And that's a pattern that we would see pretty commonly with Alzheimer's. So we can go to the next slide. This is an example of a patient with a disease called primary progressive aphasia, which more predominantly affects language function. And you can see there significant atrophy of the temporal lobes, especially there on the patient's left, the right side of their temporal lobes there. But you can see on the one side, it's very small. And so that's helpful sometimes, especially because there are some times where we have some question clinically, is there an overlap syndrome here? Is this a more atypical version of a common disease? And MRI can be helpful in helping us sort those pieces out. So we can go to the next slide. This is an example of an MRI in a patient with something called progressive supernuclear palsy, which is falls under the family of Parkinson's plus syndromes. And we often will see patients who come in with cognitive problems and Parkinsonian symptoms, and sometimes you can see that with, you know, a more advanced Alzheimer's disease, but sometimes it's a different process. So this example here, those arrows on the top picture are pointing towards something called the hummingbird sign, which is sort of when you get thinning of the midbrain, and you can see that kind of look like a hummingbird there with its beak. So, and then the bottom two are showing more notable atrophy of the cerebellar peduncles. So again, that's helpful if we're trying to figure out, is this a Parkinson's plus syndrome, or is this, you know, a more advanced stage of Alzheimer's that's also presenting with some Parkinsonian symptoms. Okay, we can go to the next one. And then the next slide shows a few different things. So that top left slide there, that's a sequence called SWI, which looks for blood. And in this one, all those little black dots that you're seeing are areas of hemorrhage. So those are called microbleeds, kind of little tiny hemorrhages someone has had in their brain. And we can see that with a problem called amyloid angiopathy, which can also cause cognitive problems. And that's useful when we can see it there because it helps point us towards a diagnosis, and also affects management. So in these patients, whereas most of our patients are coming in on antiplatelet therapy for whatever reason, have had a stroke or they've had a heart attack, you get more concerned about the risks of that in people who have amyloid because they're a higher risk of having a more symptomatic intracerebral hemorrhage. That second slide on the top right, and actually that first slide on the bottom left, are examples of vascular changes that we may see in a more kind of vascular dementia type process. So if we see a lot of those on exam, then we worry again about a more vascular dementia or kind of a mixed picture. And then the bottom bottom right is, so those ventricles are big too. And if you notice there, as opposed to, and this is a little bit subtle, but as opposed to the MRI we looked at before where there was kind of global atrophy, this degree of ventricular enlargement is a little bit out of proportion to the amount of atrophy. And you can also see the almost a little bit of crowding there near the top at the vertex. So that's more of a picture that we might see in something like normal pressure hydrocephalus. So if we saw a person come in with magnetic gait and urinary incontinence and cognitive decline, and we see that kind of picture on MRI, then we're going to be more inclined to pursue a lumbar puncture to see if there's a response there, which is what we will often see in normal pressure hydrocephalus. All right, we can move forward, I think. Oh, and then the very last one. So this would be an example of a rarer disease that we would see. And this usually would present with a more rapidly progressive dementia, but this is an example of an MRI in CJD. And you can see especially the top right one there, that kind of increased signal in the cortex is called cortical ribboning, and that's a very concerning sign if you see it in the setting of a rapidly progressive dementia, because it's more concerning for CJD. And so those are just all examples of, again, the more subtle things we can see on MRI that can be very helpful. So we can move on. So most of our patients, we will end up stopping there after MRI and clinical assessment, because often the diagnosis will become a little more clear at that point, but sometimes it's not. So sometimes we go into even more detailed testing. So another common form of imaging we may get is a PET scan. And that basically looks not only at structure of the brain, but also function. So how different areas of the brain are metabolizing. So I won't go through all of these, but the point on this slide is to note that sort of the pattern of where we may see decreased metabolism in the brain can help us figure out what the underlying cause is. And these can be useful in a couple of settings. So one is if we really feel like we need some extra confidence about the diagnosis because it may change management. So for example, if we're thinking about an Alzheimer's picture in term, versus a corticobasal degeneration, which is more of a Parkinson's plus syndrome, or even a frontotemporal dementia, which those all have different things that we may counsel patients may happen to them in the future. It's useful to get a little more diagnostic clarity. Sometimes it's useful for patients and families to have a more definitive diagnosis as opposed to, well, we think this is most likely this, but there's a small chance that it might be Lewy body dementia. Sometimes just for peace of mind from their standpoint, it helps to have sort of one name to put to everything. Sometimes it's helpful for us to, I had a couple of patients who are presenting with symptoms that are affecting their day-to-day functioning more than I am able to tease out on just what I see on their exam and what we see on their formal neuropsychological testing. And I'm trying to decide, is this more of a mood psychiatric problem, or is this the beginnings of a more neurodegenerative disease? And I just can't quite figure it out yet. Sometimes PET scan can be very helpful in that situation. And sometimes it's not helpful because we don't get a clear answer out of that, but we do pursue it sometimes. Okay, we can go to the next one. And then amyloid imaging is another one that we often don't need to utilize, but it's basically specific for looking for amyloid deposition in the brain. And so that bottom set of series of images there is a positive scan, which indicates abnormal levels of amyloid deposition in the brain. And that is useful primarily for deciding if someone does not have Alzheimer's disease. So if you have a normal amyloid scan, then Alzheimer's is less likely. And we don't go down that route all that often, because often it's not make or break for us to be able to say this is definitely not Alzheimer's disease. It may become a little more commonly utilized going forward, though, because there is a drug that's in sort of process of potentially being approved by the FDA that is potentially indicated for use in some patients with mild, sort of in the beginning stages of Alzheimer's disease. And part of determining if someone qualifies for that medication, if it is approved, is going to be either a lumbar puncture that's indicative of Alzheimer's or amyloid imaging. So we'd probably be having a different conversation about this time next year if that medicine gets approved. Right now, again, we don't use it a ton, but we do use it sometimes, so sometimes it's helpful. And then also sometimes, especially depending on whether someone may or may not be a candidate for certain clinical trials, depending on their definitive diagnosis, it's helpful. Okay. So in terms of considering whether to get imaging and what kind of imaging to get, so pretty much always we're going to get some kind of imaging on a patient to make sure we are not missing something else that's causing their symptoms. The modality you choose, again, depends a little bit on the patient's situation and what the clinical question is. It's important to remember that imaging studies cost a lot of money and are not always covered by insurance. So for example, especially when we're deciding whether to pursue something like a PET scan, it's important to think about how drastically is this information going to change our management, and what might the patient be paying out of pocket for this, because I don't really like my patients to get a $2,000 bill for something that just makes me say, okay, well, this is consistent with what we already thought and the treatment is the same anyway. So it's important to think about that. On that same, the other side of that coin is that sometimes these are, really useful tests that give us important information that helps us guide treatment for patients. So when they're necessary, but they're not necessary for every patient. It's also important to remember that some patients may have difficulty tolerating longer studies. So especially if I see a patient who is older and has a lot of other medical problems or respiratory issues at baseline, and they cannot hold still for an MRI, the risk of doing something like a sedated MRI in these patients is higher. So if I don't think it's going to tell me anything that's going to change my plan, it's probably not worth the risk to the patient. And then again, some of these more flashy studies like PET and amyloid imaging are really useful when they are, but they may not always change management, so they're not indicated for every patient. Okay. So next is spinal tap. So spinal taps are primarily useful to exclude other etiologies for someone's issues. So infection or inflammatory autoimmune problems. Sometimes they can be useful if we think there's a potential for a malignancy, although usually we're going to be able to see that on imaging scans. But we can also send things send labs for things like CJD on CSF. So most of the time, when we're pursuing lumbar puncture, it's not to make a diagnosis of dementia, it's to exclude something else that we could treat. But we can send some biomarkers on CSF, so there are specific tests we can send for levels of amyloid and tau in CSF, which can be predictive of Alzheimer's disease. Again, we don't do that all that often currently, but depending on if this medicine from Biogen gets approved, we may be doing them a lot more often. And again, that will be more to kind of solidify the diagnosis to open up that treatment option for patients. Okay, next. And then, so there's some other testing that we can consider. So genetic testing, there are several genes that have been associated with increased risk of Alzheimer's. So there's a few listed there, PSEN1, 2, APP, and ApoE. So genetic testing is something that should be undertaken only after careful thought and consideration. So you need to have a thorough discussion with patients and their family members about how much a genetic test might change the plan, because often it's not necessarily going to change the plan for the affected person, but it may very well have a significant impact on their family members, because if you know that one person has whatever particular gene, then that has implications for their children and things like that. So I almost always recommend genetic counseling for patients before I send genetic testing if the patient's willing, just again to talk about these sort of downstream effects from a positive result. It's also important to remember that genotype does not always make or break a diagnosis. So for example, people who have who are homozygotes for ApoE4 are at higher risk of developing dementia, but it's not 100% penetrance. So there are a decent percentage of patients who have both genes and don't go on to develop dementia. And so then you have to think about how much distress is this going to cause this person who may not actually ever clinically manifest this disease. And then again, there's a few more other autosomal dominant genes there. It's also important to remember that if a patient has no other family history of dementia, then one of these mutations is a little bit less likely. But they have their place too. Again, sometimes it can be useful for patients to know a little better the cause of their disease. And then sometimes for family members who it would affect, they may actually want that information in terms of their own planning, whether that be long-term kind of care planning, or even for some patients planning about whether they want to have children or not. So it has its place, but it is important not to undertake it lightly. Okay, I'm gonna go to the next one. EEG is not indicated as a routine part of dementia evaluation. You can consider it if there's concern for seizures. So if someone's having focal events that look like seizure, that would definitely be a reason to get it. Wide fluctuation in symptoms may be a reason to get EEG, especially, there are some forms of epilepsy that can cause just kind of transient amnesia or transient memory problems. But these are usually going to be like, yeah, for 5 minutes, I forgot where I was, or I lost 5 minutes of time, as opposed to like, I've been sort of steadily declining for 2 years. But again, if there's a lot of fluctuation in symptoms, then you may want to consider EEG. And in rapidly progressive dementia, it can be useful too, because with some of the infectious etiologies or autoimmune encephalopathies, there can be more specific findings on EEG that can be helpful. And then sleep studies actually have a useful part in these evaluations as well. So we are increasingly learning that sleep can significantly contribute to cognitive dysfunction, and there's a little bit of evidence that it could potentially even play a role in your risk of developing Alzheimer's. And so if anybody has risk factors for obstructive sleep apnea, or if they have excessive daytime sleepiness, a sleep study can be really helpful, again, to evaluate for things that we can fix. Okay, next. So to kind of wrap everything up, I feel strongly that our clinical evaluation is still the most important and useful tool that we have. Listening to a person's story carefully, talking to their family, and examining them are the most important tools we have. A lot of these diseases still remain primarily clinical diagnoses. We don't have a blood test that can tell us exactly what type of dementia you have in most cases. And again, when we're deciding which of these tests to send, it's important to consider cost benefits. So again, we should send the tests that are potentially diagnostic or useful, but we don't necessarily always have to get every single test just because we can. And then again, as I mentioned before, there may be more treatment options available in the not too distant future, and that may affect kind of our more standard testing algorithm. So again, probably or potentially this time next year, this talk will be different. Okay, so that's kind of a summary. I'm happy to take any questions.
Excellent. Thank you so much, Dr. Ward. That was a wonderful presentation with a lot of great information, especially when it comes to different type of testing that can be done through imagery. And also, I think you brought up a great point with genetic testing. I found that really interesting to really consider those options and how hard that could be to know or not know.
Yeah,
But
I mean,
what
I
type?
think it's hard, yeah.
Yeah, that's definitely hard. I mean, it just depends on the person with genetic counseling. That's a really nice point to put in there. Does anybody have any questions or comments they would like to make?
Can you throw some light on that vitamin B12 checking the accepted level or the treatment of B12 deficiency? What should be our goal for at the primary care level?
Yeah, so that's actually a really good question because we see it not infrequently where someone's level comes back kind of borderline, you know, it's normal, but it's at the lower range of normal. And so is this significant or not? So exam can be helpful sometimes. So often with B12 deficiency, you can see a peripheral neuropathy and also hyperreflexia. So if I am concerned at all about a neuropathy on their exam and their B12 level is less than even 400, but definitely less than 300, I will often supplement. But sometimes the other thing you can check is a methylmalonic acid, because sometimes your B12 will be low normal, but your MMA is high, and that's more indicative that it is truly deficient. And then what I would say is there's very little risk of becoming toxic on B12. So I have a pretty low threshold to at least give a trial of supplement. I will need to look and see if there's a strict consensus guideline, but I usually will try a supplement for anybody who's less than 400. But I usually do not do injections for those people. So they've done some studies actually that show that unless there's an absorption problem, injectable B12 and oral B12 are probably as effective as each other in treating a B12 deficiency. So usually, again, if it's like 350 and there's nothing on their exam that clearly says this is a B12 deficient patient, I will tell them to start an over-the-counter supplement of 1,000 micrograms a day and then recheck the level in a few months. But I am not often going straight to injections for these patients. Again, just kind of thinking about unnecessary healthcare costs. So I don't know if anybody else has thoughts on, Dr. Navia may have a thought about this too. I don't know if he's still on the call, but that's sort of my general practice pattern.
Thank you so much, Dr. Pollywall. That was a great question. Does anybody have any other insight on the B12 or have any other comments?
I have one more question about the same B12. Okay, when you are supplementing, I mean, right now the normal level of the B12 is from 250 to 1200 from our lab. And when you are supplementing, I mean, I supplement injections also when I feel that it might be an important cause and if patient is able to do it without too much inconvenience. But what target we should be look for, like when we are treating it, or we should?
So that's a good question. And I don't know that I have one number to give you for that. What I typically do, so I will say it's very rare that I have supplemented and then not had their subsequent level come back at like at least 800 or so. And I'm usually happy with that, especially if I wasn't that suspicious that it was truly B12 deficiency was the problem in the beginning. I will look and see if I can find a more strict number for you on that, and I'll get back to you. I mean, if it is a true B12 deficiency, like, you know, their level came back low in the beginning, then I'm going to want to aim for at least well within the normal range. So, yeah, I don't want to give one specific number because it'll just be me kind of throwing off the top of my head what I usually like to look for, but I will look and see if there is a more definitive cutoff and get back to you.
This is Dr. Miller. I'd like to just add something. I do the same thing you do, Melanie, just treat anything under 400, particularly in any frail elders. And don't forget where the B12 gets absorbed in the terminal ileum. So if they have malabsorption syndrome, I had one patient who was in a bar fight, was stabbed, and they took out a piece of his bowel. It turned out to be the terminal ileum. He was deficient for probably most of his adult life until he got demented from it, and then it was permanent. So I had one other patient who had gastric bypass, which, you know, they have to replace the B12 or you can get deficient. She had intractable nausea, and they sent her to a step-down care center and forgot to give her B12, and she got demented. This was a bank teller who had gastric bypass and ended up demented from B12 deficiency.
Yes, and definitely if there's a concern about an absorption problem, then I would do injections. So anybody with history of gastric surgery, or if I have, you know, supplemented them for a month or two and the levels aren't coming up, then I would think about injections. And yeah, both people we saw on our service last week who were deficient had gastric bypass and not been, one had bypass 20 years ago and just, I think, had kind of fallen off the radar, and he was a PA, and actually cognitively he got better, but he's had a B12 myelopathy, bad like sensory ataxia since September, which is when he was sort of first diagnosed. It's not getting better. So, and then we had a thiamine deficiency on our service too. So yeah, when there's concerns about absorption, then I usually would go straight to injections.
And because you mentioned about the thiamine deficiency, can you just talk more about the thiamine is it, I know with the alcohol thing, it could be hit and miss, and we mainly come to supplement when we come to know there is some kind of alcohol abuse or thing going on.
Yeah.
But otherwise.
So thiamine deficiency often, so sort of the classic triad is ophthalmoplegia, so eye movement abnormalities, encephalopathy, and then sort of the classic, more specific encephalopathy is Wernicke's encephalopathy, and that those people tend to have a lot of like confabulation and then ataxia, so gait problems. But I will tell you that there are definitely a substantial number of patients who do not present with the classic triad. So just because they don't have all three of those does not mean they don't have thiamine deficiency. And so any history of alcohol abuse or just poor nutritional status for whatever other reason, including gastric bypass, I check it. And then if I see anything on exam that's clinically concerning, so especially like nystagmus or abnormal eye movements or an ataxia on exam, then I'm more likely to send it. And then what I would say also about thiamine is that it can become symptomatic relatively quickly. So I'll look at the exact number of days, but like you can develop a thiamine deficiency sometimes within a week of kind of an acute poor nutritional event. So like a bad GI illness, it is possible to pretty quickly develop a thiamine deficiency that is symptomatic, and definitely that does not happen to everybody, because obviously the vast majority of people who get a GI illness for a week have no neurologic problems from that, but it can happen. So it's important to think about, especially if someone is presenting with a more kind of acute encephalopathy picture. And then same philosophy as B12. I mean, usually with thiamine, you're going to empirically start treatment even before the level is back, because often these people we're seeing in the hospital. So like we'll send the level and start them on high dose thiamine while we're waiting for the level to come back, because again, relatively low risk of problems if you supplement a deficiency that's not there. So again, I check it in anybody who has nutritional status concerns. And then even in a lot of people who don't, if I think there's any chance that they could be having a nutritional absorption problem, I'll check it. When as outpatient, I'm often not checking and also starting on high dose supplementation at the same time. I'm just going to put my mask on because I'm in a workroom and people are coming in, so I don't want to expose anybody else. But yeah, those are my thoughts about thiamine. She's like, oops, hold on. I'll mute here.
No worries. Thank you so much, Dr. Ward, and thank you so much,
Usually,
Dr. Polywall.
they were nice enough to let me do this in here because usually I would go over to my office, but I didn't have time to make it over there. So
It's okay. Any other comments or questions? Thank you so much, Dr. Polywall. Those are excellent questions.
yeah,
I feel
thank
like
you
I need to go
for
take
joining.
B12 right now. Is that like a thing? Should I be
So
taking that every day?
it's not going to hurt you. And people do feel like it helps them a little bit with energy. Again, I always try to think of things in terms of cost to the healthcare system. So like I do not put everybody who walks through the door on injectable B12 because even though those are not particularly expensive medications, it is cost. But if you want to go to the drugstore and buy some over-the-counter B12 for yourself, it's probably fine.
Get the gummy kind, right?
Yeah. Yeah, and thanks everybody for being patient with me. It always happens if I have somewhere I need to be, then things are gonna get really crazy at the end of the morning. So that's definitely what happened today. So I appreciate your all's patience with me.
I saw Amy Shadden said, I need some B12. Yeah, absolutely. My mom always tells me, Lisa, take your B12 in the morning. Like, it'll give you energy because I feel like I'm always tired. So, what about, can I have a question about like scanning? So if somebody is nervous to get an MRI or that type, can they, if they are sedated, does that give you the same results as if they are not?
Yes, MRI just looks at structure, so we'll get the same result regardless as long as they're laying still. And normally, like we can give people Valium or things like that to help keep them calm. And like in young, you know, so I see a lot of MS patients too, and these are young people who have no risk factors really for problems with benzos or sedation. So in those people, I'm sure everybody, you know, so if you want sedation, sure, but it does become, you just need to be a little more careful thinking about it when we're talking about other, you know, elderly people who have other health issues or lung issues or heart issues, then the risk of anesthesia is higher. And so if we need it, we need it, and we definitely order sedated MRIs on people sometimes when we think that it's going to really help us exclude something that would drastically change the treatment plan. But if it's not, then, you know, I do like to at least try to get a head CT on everybody. And then if there's not if it's not going to change our management, I'm probably not going to make them get a sedated MRI. But, you know, lots of people, we can at least try a little tiny dose of benzos if we need to. But, you know, if I have a 95-year-old person who's really fragile to begin with, I'm probably going to even be nervous to give them 5 of Valium. So I will do it if I think it's necessary, but if not, it's usually okay.
Thank you so much. Go ahead, Mark.
I would just add that
yeah, I'm good, Aaron.
When we first started out, we didn't think MRI did much except rule out other pathology. But in the hands of a skilled neuroradiologist, the pattern of atrophy that we can see can be very helpful towards diagnosis. And in many cases, we see significant atrophy in the hippocampus, and that really helps us kind of form up that diagnosis. So we see atrophy in the hippocampus and the parietal cortex. It tells us much more likely that it's Alzheimer's versus frontal atrophy for an FTD or the examples you showed for those Parkinsonism cases. So, you know, again, our skill at using these has really evolved over time. And for us, because we really trust our radiologists and they know what they're looking for here, we use it, and it really helps confirm diagnoses for us.
And I do think a lot of times there is utility, even if we're deciding between 2 diseases that have the same treatment, which is mostly symptomatic benefit. Sometimes it's really useful to hammer the diagnosis down a little bit more clearly, again, just for peace of mind for the patient and their family, and for prognosticating, and for saying like, hey, you need to be on the lookout for sleep problems when it's Lewy body, which may not be as prominent in some other things. So there's definitely, you know, when there's utility for all these tests in the right setting.
And when we see our patients back for feedback, showing them, the patients and the family members, the MRI, and helping them understand, look at the shrinkage in the hippocampus. That's why you have short-term memory problems. Look at the problems with the frontal lobes. That's why the behavior has changed. It really helps the family really kind of understand the symptoms, link it up together, and better manage them because it's not such a mystery anymore. And so we really integrate the imaging findings into the feedback for the family so they have better understanding. It just helps them take the edge off about everything.
So much for those. Yeah, thank you very much. We're about 5 minutes away from the end, so I just didn't want to make sure everybody had their questions or any other comments in before we ended the session. All right, great. Well, I'll make sure I send this in the recap and everything. Thank you so much for everyone that got to join today. Dr. Ward, that was an excellent presentation, and we had some really great comments and feedback today and questions. My only announcement is our next session will be taking place on May 4th with Sierra Keith discussing addressing roles and needs of caregivers. We look forward to that. Thank you so much, everyone, and have a great rest of your day.
Thank you all.
Thanks, guys. Bye.